I want to invite Bev Brakeman's here from Citizens for Economic Opportunity, and she's going to talk to you a little bit about what we've been trying to do in healthcare, and the bills are kind of coming out, moving along in a different committee. So this is Bev. Welcome.
Hi. I'm not the chair of anything, so I appreciate Representative Garagosian asking me to be here and talk to you a little bit. I don't know how much you know, but I can sort of tell you right now, healthcare is somewhat chaotic. There's a lot of different vehicles out there. There's overall a huge commitment to the issue. I think what we're grappling with now is how to get to something substantial. There's sort of proposals that would be more sort of market driven and build on the current system that we have. And then I think most of the legislators in this room have really signed off on more real comprehensive bills that meet some standards that have been put forward by the Institute of Medicine, that our healthcare system be universal, accessible, affordable. I see you guys nodding your heads, so you've sort of heard this rap before. So that's, basically in a nutshell, that's where we are. I mean, I have some fact sheets. There's a bill that was passed out of the Insurance Committee, Senate Bill 1371, which, was just, Representative Garagosian was huge help with that. Yep, same thing. So, and that is basically, that's a single-payer healthcare bill in Connecticut. So the fact that it was passed out of the Insurance Committee is fairly, sometimes, yeah, that's like, is pretty unprecedented that would happen. So we think it's a big deal, of course, to buy it. But, and then there's another bill that it's House Bill 7314 that was passed out of the Labor Committee, which is also a universal comprehensive health care bill signed on to by lots of members of the House, including those folks in this room, that would, it's sort of a hybrid. You maintain the current employer-based system, but then you create a large pool for others who are not insured through their employers. So without going into enormous amounts of detail, because I could, and we'd be here all night, that's sort of where we're at. We've got, the Senate President talking about Medicare for all, single-payer universal health care. I mean, that, I think, I would venture to say that most of the people in this room probably, think that's a good idea. I certainly do. And my organization, Citizens for Economic Opportunity, has been really out front on the need for a single-payer system. I mean, what we have now just doesn't work for people. It doesn't work for employers. It doesn't work for the economy. And to build on it is just, to use Senator Williams' analogy, it's like building on an already wobbly house of cards.
But whatever happens this year, they will, might not be comprehensive, but they'll be good things. They'll be things that many of us in this building have been fighting for many, many years. We're hoping to do something structural with the healthcare system, but if we're not able to, we're going to help a lot of people across the states. Things like raising the dependence age to 25 or so, on their parents' insurance, and they don't necessarily have to be students. As some of the other issues we've dealt with. Things like increasing Husky to 300%. Things like increasing reimbursement rates to physicians and other providers, which will go a long way to helping cover more people. But this is like public financing campaigns. This is an issue that's got legs and is really, Bev can tell you as an advocate.
Oh, yeah. Seriously, just getting it out of the Insurance Committee was huge. And, I give credit to the people on that committee for, I think many of them were sort of lukewarm about, the getting to single payer at the end of the day, but they were all willing to sort of keep it on the table, which, 3 months ago we wouldn't have been having that conversation.
And that's important because I believe you have to have the debate and include the whole range of options in order to make an informed decision on such an important thing like this. So.
I think that's the argument that won in insurance, that it passed with people who are against it voting for it because they had become convinced that the right thing to do was to not let it die in that committee, but to move it forward and let more of us and the state participate in this debate. And that was where the real victory came in the Insurance Committee. That's the kind of backroom, honest dealing that you're not often aware of. People have to be convinced. I know you're for it. I'm not asking you to be for it, but really, other people deserve to have the debate we've had in this committee.
And the single-payer bill has about 50 co-sponsors.
Yeah.
It's not like,
Well, let me ask you this.
It's not like some of our ideas.
It's not a few wackos in the room.
Let me ask you this: do you think that the votes exist right now to pass either this or something similar to it this year?
I'm not sure, but what I will tell you is I think that we're moving in a direction we can pass a bill that would create 5 large pools, 3 or 4 large pools, which would be a great step in the right direction because it will create a more efficient system. It'll allow us to get a hold of the rules of denial claims that the insurance industry, the games they play with that, what's medically necessary, things like that. That we're constantly having on the insurance committee having providers before us, and any of us know that had a doctor. There's more people pushing paper in a doctor's office now than there was 10 or 15 years ago, and having to play with 5 or 10 or 15 sets of rules. To the extent that we can streamline it and make it more efficient, and the extent that we can limit what they spend on non-medical expenses and profits, too, that we rein in what the costs in the system. We can cover everybody. There's a couple different ways to go about it, but philosophically, people, single payer is the most efficient way to do it. That's why I've been on the committee for 13 years, and I didn't come here as a single payer advocate per se, but I've looked at it, and it's the most efficient model. There's one set of rules. We don't have to. I guess did I answer you? I'm not sure. I think and Steve's going to talk about energy. There are 4 or 5 systemic challenges that we have. We heard about education funding. So there are a lot of big issues floating around this building this year: property tax reform, healthcare reform, energy reform. So we're kind of in flux here, and there's 80 days to go in the session. And we're not really gay marriage. It was the Judiciary Committee just take a single. Yeah, that's okay. Big issues. No, lots of big issues. We're in a kind of in flux right now. Okay.
I would agree with what he said, and what I would also add is that what you all, you guys have an opportunity. You influence the debate. You influence the public debate arguably more than most of us ever get the chance to do. And what happens in this building on healthcare, anyway, I can speak to, and certainly I think we've seen that in the marriage and the civil union debate, is what happens outside of the building is what's going to influence. So whether we end up with just Husky expansion or single-payer universal health care, we got to be concentrating on what happens outside of the building to make that more politically feasible. Because I would say probably if we had the vote right now, probably not. But we've got 80 days to figure out a way to make that happen, and I know there's a real groundswell out there.
The fundamental political question is, do you think Connecticut can fund it even if it means raising taxes?
We are already funding it.
Actually,
we spend 16% of GDP on health care. The European countries that have universal health spend about 11% of
on the
GDP.
street is it sounds great, but we can't afford it.
Well,
that's what I would say if I was against it too. I would never say that I was against people getting health care. I would never say that I disagree that health care is a right. I would say how passionately I care about that, and that really I wake up in the morning and vomit blood because I'm so disappointed we can't afford it. That is what I would say every single day, all day long. Of course we can't afford it. They're going to say you don't deserve to see a doctor when you're sick.
I identify crowd tied up in nuts because I told them it was a moral issue and it's a Christian.
Yeah. In terms of affording it, every single insurance company that deals in healthcare brags about their profit margin. Not one of them says, don't sell our stock. We promise to get out of this business. We understand there's no money to be made. They're making a fortune. If we get middle people, I'm on the public health committee. We had somebody from a home health care agency come and say, don't let patients quit our agency when their nurse quits, to follow the nurse where they go. 2 nurses left. So many of the patients whose only connection to that agency left to follow the nurses, they had to lay off 2 staff in billing. We're talking about 100% increase in staffing to cover billing over covering patient care. Now, personally, as a nurse, that looks stupid to me. If the only way I could make my living was giving bills, I might think of it differently. But the idea that a single nurse keeps more than one person employed, because that's one got laid off, but there are others who are doing administrative work, overlooking it too. For every nurse in a home health care agency, apparently, we keep more than one other person employed, at least one full-time
In that particular
employee.
case.
There's some money there to be spent on health care.
No, I'm saying just think about it.
Yeah.
We're spending the money already, and that's the educational component I talk about, both in the building and out of the building. We're already spending 16% of GDP on healthcare.
Yeah. 30% of our healthcare dollar goes toward administration and profit right now versus in Medicare, it's 3%. You know, I mean, Aetna, the former and the current CEO, $68 million last year. That's obscene. That's where our healthcare dollar is going.
That's how we afford it. The governor of the state of Connecticut.
It's the question.
No, it's going to have to be phased in over time. But I mean, but the governor of the state of Connecticut makes $200,000 to run a whole state. I mean, so you don't need to make $68 million to administer a healthcare system.
Here's the bottom line. What we have to talk to that, because it's the reality on the ground. Right now, individual, families and businesses pay for healthcare right now, and that's the way it works. We're talking about the way 1371 has it, or whatever structure. Look at the analyses from the Universal Healthcare Foundation. Whatever the funding stream is, we're going to replace what people are paying now with a lower amount under the system that we're proposing. Businesses would pay less, and individuals and families would pay less. So we're replacing what they're paying now with a lower amount that they would have to pay under the new system.
But the only way you can sell it is
Can we
if
afford
you
that?
explain
Can we afford to spend less?
You have the votes to get it done.
Can we afford to spend less is the question.
Do you have the votes to get it done?
The only way you're going to explain
Well, we're in
it is
flux.
to make
We're really in
to explain to people that the way you're getting this is that you're bringing administration costs down, because I hope that's the way you're doing it. Like you said,
Things like advertising, things like non-medical costs.
30%. Like you said, I mean, I was on when I worked for the town of Branford, we were on a committee for the healthcare too, and they came in and told us, well, we can lower it from our if you take this risk, we can lower what we charge to administer your program from 28 to 23%. But you'll take a big. And I said to the guy, well, if I was on Medicare, it's 3%. Those are numbers that sell people. I mean, this is crazy. Exactly. I mean, it costs the town of Branford $12,000 a year for my health insurance. Of course, for my for my family. I mean, that's not. And to know that 4,000 of that is not going to health insurance. It's not going to. I mean, it's close.
That's
the way you got to sell it.
We